Uroflowmetry. Uroflowmetry is the least controversial urodynamic parameter. It has been proposed that peak flow rate of less than 10 ml per second is associated with obstruction and over 15 ml per second is normal. However, any flow rate could be associated with either obstruction or lack of obstruction. The potential drawbacks of uroflowmetry are as follows. The volume voided may not be sufficient for proper interpretation. Interrupted stream or post-void dribble makes the calculations and interpretations difficult. Some patients may not be able to void as they normally do in the machine. The same person may void with different streams at different times. CYSTOMETROGRAM or bladder pressure studies. Filling cystometry provides information on sensation, compliance, the presence and threshold for involuntary bladder contractions, and the functional capacity of the bladder during the filling phase. The maximum voiding pressure and the post-void residue are other parameters that are assessed. Men normally have a maximum voiding pressure of about 60 centimeters of water. Although there has been considerable disagreement regarding the use of pressure flow studies for evaluation of outlet obstruction, successful treatment of BPH by prostatectomy is generally correlated with significant reduction of maximum voiding pressure. However, the trouble is that reduction of maximum voiding pressure may not translate into symptomatic improvement. There is also a lack of correlation between the maximum voiding pressure and the symptoms. The natural history of patients with BPH. The symptoms due to BPH are progressive over time. However, spontaneous improvement could occur rarely. About 60% of the patients have worsening of their symptoms over a 3 to 5 year period. The dreaded complication is acute painful retention of urine that can occur in about 4 to 73% of patients studied over a 10-year period. The average reported incidence is about 3% in 3 years. Evaluation of patients with lower urinary tract symptoms. A variety of symptom scores have been developed to objectively assess the severity of the symptoms. A group appointed by the Food and Drug Administration of USA in 1975 first developed this. It was then modified by the American Urological Association and then adopted by the WHO as the International Prostate Symptom Score. 7 questions are asked and the responses are graded. Grade 5 is given when the symptom is always there and grade 0 when it is not there. Grade 3 is given if the symptoms is present half the time and grade 4 if it is present more than half the time. Grade 1 is given if the symptom is present less than 20% of the time and grade 2 if present between 20% and half the time. Thus the scores range from 0 to 35. The questions are as follows. Over the last month, how often have you had to have the sensation of not emptying your bladder completely after you finish urinating? Over the last month, how often you have to urinate again less than 2 hours after you have finished urinating? Over the last month, how often you have found that you stopped and started again several times while urinating? Over the last month, how often you found it difficult to postpone urination? Over the last month, how often you had a weak stream while urinating? Over the last month, how often you had to push or strain to begin urinating? Over the last month, how many times did you most typically get up to urinate from the time you went to bed until the time you got up in the morning? For the last question, the scoring is different. If more than or equal to 5 times, the score is given as 5, while 1 is given for the number of times the patient gets up. A quality of life question is also asked and is graded as follows. The question asked is this: if you were to spend the rest of your life with your urinary condition just the way as it is now, how would you feel about it? It's 1 if they say pleased, 2 mostly satisfied, 3 do not know whether satisfied or not satisfied, 4 unhappy, 5 terrible. An AUA symptom score of 8 to 18 is moderate, while more than that is severe symptoms and less than that is mild. There are several drawbacks of using only the symptom score for evaluation. They are as follows. They do not correlate with or predict urodynamically documented bladder outflow obstruction. A variety of non-prostatic causes produces similar symptoms. It is difficult to find out how badly the symptoms bother the patient. Some symptoms are bothersome, while some others are not. Some studies have shown that symptom score change of 3 implies slight improvement, while greater than 9 implies marked improvement. Perhaps the softest but most important may be the quality of life index. Indications for treatment. The indications for treatment varied widely over time, depending on the risks for surgery and anesthesia, and the availability of modern medication and social background of the patient. However, there are some absolute or near absolute indications like refractory or repeated painful urinary retention, azotemia due to BPH, significant gross hematuria, recurrent or residual infection due to BPH, vesical calculi due to BPH, large residual urine, overflow incontinence, or a large bladder diverticule due to BPH with a contractile bladder. Apart from these, the decision for surgery is individualized to the needs of the patient. A variety of treatment options are available. 1. The alpha blockers. About half the urethral pressure in patients with BPH is contributed by alpha receptors. About 60 to 85% of these belong to the alpha 1 subtype. Phenoxybenzamin was the first non-selective alpha blocker that was used. Prazosin, which is a selective alpha 1 blocker, was then developed. Since prazosin required thrice a day dosage, terazosin and doxazosin that permit once a day dosage were developed. Tamsulosin, which is super selective alpha 1 blocker, was then developed with a view to reduce the vascular and central side effects. Side effects include orthostatic hypotension, dizziness, fatigue, nasal stuffiness, and ejaculatory disturbances. The 5-alpha reductase inhibitors. Finasteride is a competitive selective inhibitor of type 2 5-alpha reductase. It does not reduce dihydrotestosterone levels to castrate level because circulating testosterone is still converted to DHT by type 1 5-alpha reductase in the skin and liver. The prostatic DHT level is reduced by about 80 to 90%. It does not lower plasma testosterone. It reduces the prostate volume by 20% and PSA level by 50%. Treatment with finasteride reduces the chance of acute retention by about 75%. This could be used in combination with alpha blockers. However, some studies have shown a statistically significant improvement with combination. Balloon dilatation with 2 to 5 atmospheric pressures for 5 to 20 minutes was popular for a while, until it was shown that the improvement was no greater than that after a simple cystoscopy.